And
Okay.
before we send ours with the pre-recorded.
Okay. Please committee for the recording video. And for all the participants, if you want to ask about the presentation from our speaker, you can write in the chat column. And maybe in the last season, I will try to read it in all of 5 hour speaker. Thank you. For committee, I think there is no voice or sound, I think.
TBI that required medical attention. The main causes of TBI in that age group were falls and sport injuries. We also know from epidemiological studies that approximately half of TBI happens in middle-aged people due to traffic accidents and assaults, and in the elderly people due to falls, with the majority, up to 95% of all TBI being mild in severity. If we now combine those estimates for all age groups together, then it appears that about 50% of the world population, or about 4 billion people, have experienced at least one TBI in their lifetime, with the huge cost of about $400 billion annually. Let me now show you why TBI is also a silent disabler. Epidemiological studies show that various types of cognitive problems occur in up to 55% of people who have experienced TBI. There is also a high prevalence of post-TBI fatigue, daytime sleepiness, stress disorder, and difficulty driving a car. Moreover, there is growing body of evidence that a history of TBI is associated with the risk of very prevalent and disabling other neurological disorders such as stroke, dementia, and Parkinson's disease. Taking all these consequences together, you can see that even mild TBI can lead to large proportion of very prevalent and disabling complications. If even a small proportion of these complications can be avoided or reduced in prevalence, you can imagine the health and economic benefits of that. In my talk, I will be particularly focusing on the amelioration of one of the most common problems post-TBI, cognitive impairment. But before I start describing our trial and its results, let me outline what TBI actually means and some pathophysiological changes in the brain it can lead to. Traumatic brain injury is an injury to the brain from external medical forces. It is the WHO definition of TBI. It may result in micro or macro bleeds of the brain, kind of brain bruising, or around the brain, such as subdural hematoma, you're all very familiar with. However, most commonly, it results in diffuse axonal injury, with a cascade of different pathophysiological mechanisms that may lead to various, often quite disabling consequences, as I just presented to you in previous slide. According to the World Health Organization classification, there are 3 levels of TBI severity. The least severe level is mild TBI, which, as I showed you previously, occurs in about 90 to 95% of all TBI cases. It is defined as a TBI with a Glasgow Coma scale of 13 to 15 and or post-traumatic amnesia lasting less than 24 hours. Even a very brief loss of consciousness, just a few seconds after head injury, is suggestive of mild TBI. Instead of losing consciousness after head injury, people may experience seeing stars, being dazed or confused, and these are also very suggestive symptoms of mild TBI. Anyone else with more severe Glasgow Coma scale or longer duration of post-traumatic amnesia are considered to have either moderate or severe TBI. I will be focusing in my presentation on the amelioration of cognitive problems after mild TBI primarily. Epidemiological and special cognitive studies after mild TBI show that of cognitive functions, the most commonly affected are the ability to multitask, planning and making decisions, and switching between tasks. The poor cognitive recovery post-TBI was linked to oxidative stress and excitotoxicity, and antioxidant therapies, including MLS 901, have demonstrated efficacy post-TBI in preclinical studies. All of these observations provided a rationale for our pilot trial in which we tested safety, tolerability, and preliminary efficacy of MLS 901 on NeuroAid for cognitive recovery post-mild TBI. This evidence formed a rationale for our trial. You may be surprised, but despite the huge and actually increasing burden of TBI in the world, there is surprisingly little proven effective medical treatments of TBI, particularly in the area of post-TBI cognitive impairment. That is why about 5 years ago, we started a pilot RCT to ameliorate post-TBI cognitive impairment. The final results of the trial were published in the European Journal of Neurology in 2018, as you can see here. And the trial followed all good clinical practice recommendations, including registration, ethical approval, and so forth. The medication tested in this trial was MLS 901 compound, which has been used in traditional Chinese medicine for centuries. It is basically NeuroAid. It consists of 9 herbal ingredients listed here. These ingredients were shown to have antioxidant and neuroprotective properties in animal studies. These studies showed that MLS 901 can protect neurons from dying after TBI and also has stimulating effects on the growth of new neurons and neuronal connections. MLS 901 was also very extensively tested for post-stroke recovery in phase 2 and phase 3 randomized controlled trials. For the trial, we used standard WHO criteria for TBI, and although the trial was funded by the pharmaceutical company, the trial design, running, and reporting of final results were done independently by our research group. In this sense, it was an academically driven trial. It was a placebo-controlled pilot, double-blind, randomized controlled trial in which we asked the consented participants to take 2 capsules of the trial medication 3 times a day for 6 months. Online randomization was used to ensure a balance between the 2 groups for major prognostic risk factors, shown here. We plan to recruit 140 study participants to get reliable estimates of the safety and preliminary estimates of the efficacy of the intervention in improving cognitive functioning. The main outcome measure of the trial are listed here. Apart from the safety estimates, we also wanted to explore efficacy of MLS-901 on cognitive, physical, and emotional outcomes and quality of life at 6 months after randomization and 3 months after the treatment finished, to examine the sustainability of the treatment effect over the 3 months. These estimates were required to inform a design and power calculation of the full-scale randomized controlled trial. As you can see here, we use a rather wide inclusion criteria and narrow exclusion criteria to increase generalizability of the trial results. Here are the preliminary, primary, and secondary outcome measures. As you can see, primary measures were limited to cognitive functioning and safety or tolerability of MLS-901, while secondary measures included physical, emotional, and quality of life measurements. All these measurements were fully validated and used in many other randomized controlled trials. For the cognitive outcome measures, we used validated ACNS vital signs computerized testing. Primary analysis was the intention to treat analysis. To deal with repeated measurements, which could lead to biases, we used repeated measure regression analysis adjusted for all covariates. Here you can see that the 2 groups were very well balanced demographically and clinically, suggesting that randomization was done properly. In our pre-planned interim analysis of the first 79 study participants, we found a statistically significant and clinically significant effect of MLS-901 on complex attention. And as you can see here, this important metric of cognitive functioning virtually did not change over the entire 9 months follow-up period in the placebo group, shown on the graph by the red solid line. but showed a steady improvement in the MLS 901 group. And this improvement was slowed down after the treatment was completed at 6 months post-randomization as expected, but still remains statistically significant. Such pattern is highly suggestive of causal associations between treatment with Neuro 8 or MLS 901 and complex attention, virtual ability of multitasking. As it was unethical to continue the trial, an independent data safety and monitoring committee decided to stop the recruitment at this stage, and that is why we did not recruit 140 patients as originally planned. We also found a statistically significant improvement in another important primary outcome measure, executive functioning. Although the trajectories of the executive functioning improvement was similar in the two groups, black solid line, a line stands for Neuro 8 treatment, and red solid line stands for treatment with placebo, which is suggestive of spontaneous recovery from executive functioning. The difference between the groups reached a statistically significant difference at 6 months point time in favor of the MLS 901 treatment. And as you can see here, the trends in the two groups were diverging, which is also suggestive of causal effects of Neuro 8. There was no statistically significant difference in any other primary outcome measure related to cognitive functioning. Among secondary outcome measures, the only outcome that was statistically significant at 6 months after randomization was quality of life, which was better in the MLS 901 group compared to placebo, as you can see on the graph. And after 6 months, there was no change between the group, statistically significant change between the group, also suggesting that the treatment effect does relate to the use of MLS 901. As you can see here, there were no significant, statistically significant differences between the groups for any of the other outcome measures. Another primary important outcome measure was side effects. And side effects, as you can see here, actually occurred more often in the placebo group than the MLS 901 group, strongly supporting very good safety profile of MLS 901. We also found a pretty good adherence to taking the medication across all time points. 84 to 89% adherence is generally considered as a very good adherence in any pharmaceutical trial. The main strengths of our study are shown here: prospective, placebo-controlled, double-blind, randomized controlled trial with proper randomization, robust data analysis, relatively large sample size for a pilot trial, and high level of generalizability. However, as with any study, our randomized controlled trial was not free from limitations, with the first one being inherent for any pilot trial because of the possibility of type 1 error. And the second one related to the fact that we only had 2 moderate and severe TBI study participants. So the application of our study findings is limited to mild TBI subjects only. The main conclusions of our study are: first, treatment with MLS 901 results in clinically and statistically significant improvement in complex attention and executive functioning. Second, MLS 901 is very well tolerated post-TBI with no side effects. And finally, our trial suggests that a full-scale RCT is certainly warranted. And I am very happy to inform you that at this very time, the full-scale phase 3 randomized controlled trial, multi-center trial, is currently under final stage of preparation in Russia. Finally, I would like to acknowledge all my team members, the sponsor of the trial, Moller Company, health professionals who helped with the trial recruitment in New Zealand, and of course, our study participants. Thank you for your attention.
So I think our first speaker is finished. Now we're going to our second speaker. Maybe Dr. Asra is now in here in our session.
Yes, please.
Okay, thank you.
I have a pre-recorded movie. Yeah.
Okay, place and time for you, Doctor.
Yes. Please, my recorded movie committee. Good morning, ladies and gentlemen. I hope everything is okay with us now during this pandemic situation. And this time I would like to present my presentation with the title of Narrow Aid in Traumatic Brain Injury. Yeah, this is my disclosure. And yes, we all know that traumatic brain injury is still a health issue and problem in our medical situation. You can see here more than 50 million people affected by traumatic injury annually worldwide. And you also know that this kind of disease is a leading cause of mortality in the active or working population. This head trauma is one of the major causes of disability. Falls and road accident are among the main causes, and you can see the number of global costs in economic perspective. So this is a real health issue of head injury worldwide. So I will show you the impact of TBI, how this kind of disease is a leading cause of death and disability globally. You can see the incident comparing with stroke, how it impacts the economic factor. For example, in the USA, you can see the number there. Also, it is the #1 case of brain damage in children and young adults. So this is you can see this is the reproductive age in our population, and also about 1/3 of people experience TBI by the age of 30. You can see that head trauma, one of the impact is the cognitive function. So I think it makes a problem for our reproductive age population globally. And you can see the number of the epidemic data globally about the number of TBI per every year compared with stroke. So I will show you how the pathophysiology, how they with a recovery in our TBI patient. You can see we cannot do much for primary injury, but we can make some best treatment to prevent secondary injury. Injury mechanism and treatment strategy is very important one. Okay? You can see there how we make some strategy until now to prevent secondary brain injury. So it's about the neuroprotector, neurovascular modeling, and also increase the functional recovery. Yeah. Instead of primary injury and fail of secondary injury treatment, so it will have impact to the mortality and also behavior, cognitive, and motor functional deficit. So you can see, I think we all neurosurgeon know this is the the guideline for management of traumatic brain injury, but I think until now no protector agent in head injury is effective. Okay, mostly it cover about the preoperative management, surgical strategy, and also some mechanical management. Yeah, beside the pharmacotherapy treatment too. So I think everyone know about this medication, citicoline, and I will show you this paper of systematic review and meta-analysis of this kind of drug that have been using in head injury. So the conclusion is the available evidence doesn't support current routine use of citicoline for acute TBI. And also citicoline used for managing impaired neurocognitive condition in chronic TBI is weak and need further research. So I think you already know about the this MLC 601 or the new one MLC 901. This is a mixture natural component. So this is I show you the MLC 601, but in the new product of MLC 901 without these five animal components. So how about the research about this neuroid drug in TBI? You can see many reports. This is in 2014, and the last one from Dr. Rohadi, Indonesia, I think in 2020, and also this from I think Neuroimmune Pharmacology Journal. Yes. It also in 2014 about I think this experimental model in rat. This research was conducted. So yes, the three of this journal concluded some mechanism of action of neuroid. First is neuroprotective effect after TBI, neurorestorative effect after TBI, neurogenesis after TBI, and also the neurological recovery after TBI. So we can, make some list of this neuroid post-TBI property. So the multimodality effect of neuroid is neuroprotection, reduce dendritic damage and cell death, and you can see, you can write there, reduce edema, and also improve memory, cognitive, and neurological recovery. So I think we already know that mostly in earlier report about neuroid, it's always about stroke, and some some multi-center study showed it this neuroid have some beneficial effect for stroke patient. Yeah. But how in head injury? Yes, I think until now we have only limited reported in the journal about neuroid trial and head injury. I think until now I can I can collect about 3 trial on head injury in using this medication, using neuroid. First is from New Zealand, and and the other from Indonesia. I performed this trial, this research, and also the last one from Iran, I think. Yeah. Brain study from New Zealand, brain injury and experiment. This research is the goal is how is narrow eye can improve the cognitive function after a TBI in patient. And the conclusion of this research is, you can see here, that narrow eye was safe and well tolerated post TBI. And also the study provided class 1 and 2 evidence that for patients with mild to moderate TBI, 6 months of narrow eye improve cognitive function. So this good report about how TBI can affect good benefit for TBI patients, especially with cognitive function. And our study, Neptune trial in Surabaya, Indonesia, the neurological prognosis after brain trauma and use of narrow eye with the subject of moderate head injury with conservative management. The conclusion is in this research, MLC 601 showed potential for a positive effect on clinical outcome with no adverse effects. So this is a good result to how narrow eye can have a benefit to in our as a drug treatment in our TBI patients, especially in this case is a moderate head injury patient. And the last report is from Iran. This is also research in moderate to severe traumatic injury patient. This is a randomized double masked placebo controlled trial. And the conclusion in the study is narrow eye has been shown promising efficacy in patients suffering from moderate to severe TBI. So I think if we talking about this narrow eye for TBI treatment, so the conclusion is the use of narrow eye in head injury is safe and well tolerated. In these 2 pilot clinical studies, narrow eye showed promising clinical outcome and improvement of cognitive function in patients with head injury. And of course, we need a future randomized controlled trial with larger population, with a multi-center study to make some broader conclusion about this narrow eye in the management of traumatic brain injury patient. Thank you very much.
Thank you, Dr. Asra Al-Fauzi, for your very quick presentation.
Dr. Teddy,
yes.
Sorry, because some speaker with the pre-recording not clearly. I think if the speaker live here, maybe a live presentation. So.
Okay, I think now. Okay, thank you, Dr. Radi, as the committee for the ACNS program. I think the third one, our next speaker is Dr. Iwayan Niriana. Dr. Iwayan Niriana, do you monitor now in here in our session?
Yes, thank you, Dr. Teddy Apiawan.
Yes, please and time
thank
for
you for Dr. Hadi and committee, the ACNS. I'm sorry because I have already recorded my presentation because I didn't bring the PowerPoint now. Please adjust my record to presentation. Thank you.
Okay, sir. Thank you. Dr. Rashid?
I'm sorry, sir. There is no file we have. Maybe we will find it in MI.
Can you check in PIC and the team?
Yes, sir.
I have already sent to the, I don't know the name, but I already sent. Okay, if you waiting for that, maybe another presentation first you can make, and I will resend my presentation.
Okay, thank you, Dr. Iwan. I think maybe we going to our fourth presenter. Now it's time for Dr. Rohadi, I think. This is your time and place. The fourth speaker is Dr. Rohadi. Place and time is for your Dr. Rohadi.
Okay, Dr. Terry, thank you very much for your time. Do you look my presentation?
Yes, yes.
Okay, now we will report about our research about the effect of MLC 901 in brain-driven nerve prefecture level, then driven mRNA messenger RNA expression, TNF-alpha level, and brain histopathological in rat and with the traumatic brain injury. We know before the two speakers presented about the traumatic brain injury is major problem in the worldwide, and any case in the clinical and emergency setting is with the dominant with the traumatic brain injury and higher mortality and morbidity in especially in Indonesia and our country. For example, in our department, you know. And the therapy must be comprehensive with the pre-hospital care, hospital care, and with the strategy, we must treat about the primary brain injury and management of the prevent secondary brain injury, and we optimize about the facilitating for the optimization of the metabolism after the trauma. This, for example, for our department in Lombok area, and this traumatic brain injury with the characteristic and clinical outcome in Lombok. Majority is male, and majority cause of the trauma is motor vehicle accident. Now we know about the neuroprotectant. Neuroprotectant is a prevent to secondary brain injury with the, for example, neuroprotectant drug and neuromodulator drug. And the strategy is maintains brain perfusion, lowering brain metabolism, inhibiting mediator during injury, controlling intracranial pressure. And we know in the brain, TNF-alpha is acute and chronic phase. This is a marker of the inflammatory. And recovery, the brain with the recovery and regeneration ability. And we know in the literature, BDN, brain-driven nerve fracture, is a role in the process of recovery and regeneration of the brain. This is a biomarker in the laboratory. And in our research, we evaluation with the concentration of brain-driven nerve fracture, messenger RNA, serology BDNF, TNF-alpha, and termination with the histopathological. And we give MLC 901 or Neuro82, which we know about effect the neuroprotective and neurorestorative effect. We know in the free before two speaker with the research in the clinical we interesting to the how in our experience the clinical to how neuro aid to give a good clinical for the patient, and we must research about the how to biology molecular for the regeneration and recovery. And we interested to the effect of MLC 910 for the BDNF level, BDNF MRI expression, TNF alpha, and brain histopathological in the rat with the traumatic brain injury. And this we know about the pathophysiology of brain injury. Increasing the intracranial pressure and use make the apoptosis increase, and this is a cycle for the increasing of oxytoxicity and increasing of apoptosis and necrosis, and intracranial pressure increasing. Before research, we know about the literature for the biomarker of the traumatic brain injury in acute phase and the chronic phase. For example, neuron cell body marker, NSA, MBV, axon marker is SBVDV, tau protein, neurofilament protein, and astroglial cell marker is glial fibrillary acidic protein, and other biomarker is TNF alpha, interleukin, cytokine, messenger atau microRNA, asam uric acid, BDNF, dan metabolic profiling. BDNF we know about BDNF is a neurotropic factor, and that the support of differentiation and maturation and survival of neuron in the nerve system, and it will exhibiting a neuroprotective effect in the adverse condition. For example, cerebral ischemia, hypoglycemia, neurotoxicity. BDNF stimulated and controlling to the growth of new neuron for neurogenesis in the nerve stem cell. BDNF protein and messenger RNA BDNF have been identified in most area of the brain, including olfactory bulb, cerebral cortex, hippocampus, anterior forebrain, mesencephalon, hypothalamus, brainstem, and spinal cord. This is targeting about the BDNF from the for the neuroregeneration and plasticity in neuron. If a neuron with distress and damage, is a stimulation for the BDNF to stimulate the neurostem cell and progenitor cell to activate the repair of neuroplasticity. In the previous study about the BDNF, for example, from Palia, Simon, Tara, Chiriati, Herzog with administration in evaluate about the concentration and resulting about the many study about the BDNF is BDNF is associated with the neuroplasticity and the neuro repair. How about the TNF alpha? TNF alpha is produced by microglia, astrocyte, endothelial cell, and neuron. Function as induction of necrosis and stimulation of growth and cell differentiation. The effect is TNF alpha in chronic phase of the brain injury is very important as a neuroprotector. This is a previous study about the TNF alpha for the traumatic brain injury sample from the Jan, Stoffer, Goodman, Frugier, Heikel, that all and previous study resulting about the in the chronic phase TNF alpha is effect is good, but in the acute phase maybe is not good because is a neuroinflammation marker in the acute. we know about the MLC. MLC 901 is a traditional Chinese medicine, different with the MLC 6.1 of Professor Tess and Professor Azra about this combination about the natural and from the traditional Chinese medicine. A good base is effect of neuroprotection, and in the chronic phase, benefit for the neuroregeneration. This is a hypothesis from the framework brain injury with the primary brain injury, secondary brain injury, hypoxia, ischemia with the decrease of ATP, and MLC 9.101 is effect for the acute and the chronic. This is my time schedule research for the study for the acute phase and the chronic phase, and we explanation about the expression of BDNF, TNF alpha, and the termination with the we explanation about the pathological study. This my study about the modified Marmoro model. The effect of MLC 901 to the BDNF mRNA expression, the increasing of plasma BDNF level in the 6 weeks after brain injury was direct proportional to the BDNF mRNA expression, with the was characterized by increasing BDNF and messenger RNA expression. The use of MLC 901 agent can stimulate BDNF expression in the brain tissue after expressing focal and global ischemia in experimental animals. How about the effect of BDNF level after 6 weeks after brain injury? BDNF level were higher than placebo. And BDNF level are associated with the incomplete repair after brain injury. BDNF level is in plasma, and CSF influence mortality after brain injury. And circulating BDNF level are low in acute phase of the stroke and low level associated with the poor outcome. About the effect of MLC 901 in the TNF alpha, in our study show about the significant difference in the mean TNF alpha level seen after MLC 901 administration after 6 weeks after brain injury. And experimental study in brain injury patient, that TNF alpha has role in mediate neuronal death in acute phase and promoting of neuronal repair and neuroplasticity in chronic phase. TNF alpha contribute of the axonal sprouting and the functional recovery after traumatic brain injury. TNF alpha has a beneficial role in the post-chronic phase of the brain injury. TNF alpha mediated the neuro repair process and neuroplasticity in chronic phase. This is a significant difference between level BDNF messenger RNA, and TNF alpha within before treatment and after treatment. How about the effect of neurogenesis expression of synaptopation? Administration of the MLC 901 can increasing neurogenesis is indicated synaptopation expression. The increasing of expression of synaptopation neuron indicate there is good nerve cell differentiation, positive effect of MLC 01 neuroplasticity, increasing neurogenesis, neural growth, axonal growth, dendritic arborization, and synaptogenesis. This is immunohistochemical picture in the research. How about the correlation between synaptopation expression in plasma BDNF messenger RNA, and plasma TNF alpha after 6 weeks after MLC 901 administration? There was a significant positive correlation between synaptophysin expression and BDNF plasma and messenger expression. And TNF alpha positive but insignificant correlation. Overall, the pathology of analysis test proved the hypothesis, but the effect of giving MLC 901 is can increasing neurogenesis with the TRPV3 pathway, BDNF alpha, BDNF messenger RNA, and TNF alpha. Conclusion and suggestion. Conclusion: administration of the MLC N01 is in the traumatic brain injury can increasing the number of neurogenesis after traumatic brain injury, with the pathway increasing neurotropin factor influence of neuroinflammatory pathway. Following number one is was increasing BDNF plasma level after administration in the traumatic brain injury and 6 weeks after the traumatic brain injury. There was increasing of BDNF alpha messenger RNA expression after administration of MLC 901 after traumatic brain injury. There was increasing of TNF alpha level after administration of MLC 901 in 6 weeks after the trauma. There was increasing of number of neurogenesis after administration of MLC 901 in after 6 weeks after trauma, is with the evidence with synaptophysin immunohistochemia and marker of neurona. Suggestion: maybe further research and role of MLC 901 in regulation factor related to brain injury process. Order obtain reference data and long-term use MLC 901, especially in human. Further study on the comparison of MLC 901 with the other therapy in management of the traumatic brain injury. Thank you very much.
How we copy this from Dr. Muhammad Hayat? How we can do now that our method is not thank you so much, Dr. Hadi, for your presentation. I think Professor Valery is in here. I'm sorry, Professor, your recording video has been presented 1 hour ago.
Oh, I'm really sorry. Clement told me 7:30 p.m. New Zealand time. I joined exactly at 7:30, but appeared to be early. But anyway, I don't want to interrupt your session. If there are any questions about MLS 901 on traumatic brain injury on our randomized controlled trial, what we tested in New Zealand, please go ahead, and I'm happy to answer your questions.
Yes, thank you, Professor. I think your presentation is very, very great. For every participant in here, if you want to ask to Professor Valery, you can make some question in the chat session in below, and I will read your question to Professor Valery in the end of the session. It is okay, Professor Valery?
Yeah.
Okay,
all right, thank you. Sorry about that.
Thank you so much, Professor. So I think the committee told me that for Dr. Wayan Nirwana, the video is ready. So Dr. Wayan, are you still monitoring here?
Yes, please continue.
Okay, thank you, Doctor. Committee, please for the video.
This time I will present my research with the title Characteristic of Traumatic Brain Injury in Sanglah Hospital, Bali, Indonesia, a retrospective study. I am Wayan Nirwana from Neurosurgery Division, Department of Surgery, Faculty of Medicine, Udayana University, Sanglah Hospital, Bali, Indonesia. As we know from CDC 2014, 2.87 million traumatic head injuries who came to the emergency and inpatient unit. From National Basic Health Research 2013, 8.2% prevalency of injury data in Indonesia, highest in South Sulawesi and the lowest in Jambi. From Global Status Report on Road Safety 2018, death from traffic accident, about 7% of the world population. 1.35 million people die due to traffic accident annually due to head injuries. From data of Haji Adam Malik Hospital Medan, head injury mostly occur at the age 18 until 35 years. The incident 150 until 200 people for 1 million population. But in Bali, there is no epidemiological studies available to date. So the purpose of this study is to describe the characteristic of traumatic head injury patient at Sangla Hospital, Bali, Indonesia. This research is a retrospective study centered on Sangla Hospital Denpasar as a single center. Data were collected from 1 January 2015 until 30 December 2017. Inclusion criteria were patients with diagnostic of traumatic head injury, and incomplete patient medical record data will be excluded from the study. The data that we collected review from medical records as demographic information, mechanism of injury, history of previous injury, type of injury, number and type of bleeding, 24 hours survival after head injury, and from pre-hospital status, history of unconsciousness before hospital admission, duration of unconsciousness, time intervals to the hospital, and from survey, level of awareness or GCS, condition of the presence of airway disturbance, sign of impaired oxygen circulation. The result is, from this table, we can see gender, male and female is equal. There is no significant significant difference. From the age is mostly patient with age 19 until 40 years. And there is a significant statistical difference. Become more than 40 years, the patient of count is more died. And from history of head injury before, there is no significant difference. And the cause of injury is mostly traffic accident. The history of unconsciousness, yes, most of patients have no history of consciousness who died after 24 hours. And duration of unconsciousness is most of the patient less than 10 minutes. The time come to the hospital, most of the patient came before 1 hour. And GCS on admission, most of patients came with mild head injury, GCS 14 until 15. But with the GCS become lower than 14 or severe and moderate head injury, most of them is become died. And that is a significant statistic. From this table, we can see most of patients, 69% who came with oxygen saturation less than 90% died. If we compare with there is no history of saturation less than 90%, and there is significant statistic difference. Most of patients with airway obstruction, 69% too, came and become worse if we compare with 8.4%. There is no airway obstruction, and there is difference statistically. From the type of injury, most of patients came with blunt head injury. And from the number of types of bleeding, most of the patients come with one type of bleeding. But if we see from the multivariate analysis between independent variable and outcome, more than two type of bleeding, the patient have a worse outcome or become dead after 24 hours. From the logistic regression analysis of mortality in the first 24 hours among traumatic head injury, that we can see most of them have a significant statistic, like age over 40 years old, there is 2.02 p-value, and then GCS less than 9, airway obstruction, intracranial hematoma more than 2 type, and time to hospital more than 1 hour. So from the age group, in our studies, head injuries were found to be highest in the 19 until 40 years age group, with the commonest cause of injury was traffic accident. Balestri et al. Found the age and outcome of head injury were highly correlated. Age 30 until 60 years have a higher mortality rate than younger age group. From gender, in our studies, the incident will occur more in male group, but there is no significant difference was found between outcome with sex. Bayer et al. Men were more at risk of head injury and associated with occupational risk that have higher physical level than female. Liu et al. Male compared with female in both young and elderly. In young, 10/1 and elderly 4/3. Munifen Ketapa et al. The quantity of head injuries and deaths was more common in female than male in pediatric and elderly population. Ma et al. Conclude that female as steroid hormones as neuroprotective effect. History of previous head injury. In our studies, there is no significant difference between history of head injury and outcomes. But Soviet et al. Found that 80% of head injury patients with history of minor head injuries were correlated with outcomes. Impaired oxygen and airway disorder. In our study, the existence of airway disorders and oxygen saturation less than 90% or PaO2 less than 60 millimeter mercury are significantly associated with the risk of death. Therefore, the need for adequately airway handling in traumatic head injury patients to reduce the risk of death. In our studies, we found that mortality risk was increased 5.65 times in traumatic head injury with presence of more than 2 types of intracranial hematoma. Meretz et al. Found that mortality rate was higher in older patients and presence of more than 1 type of bleeding. Our studies have limitation because we are in urban area, so unable to represent condition elsewhere in Indonesia. And this is a retrospective nature, so limited clinical information and medical report. Patient outcome were not assessed using Glasgow outcome scale. So we assess only by dead or alive after 24 hours. And from this research, we can conclusion this is the first study which described the characteristic of traumatic head injuries in Bali. Traffic accidents are mostly experienced by men and patients aged 19 until 40 years. Impaired oxygen distribution to the brain and other vital organs is the fastest killer in injured patients. The existence of airway disorders and oxygen saturation less than 90% or POU2 less than 60 mm mercury are significantly associated with the risk of death. Further research is needed with more than one research center, more sample size, longer time frames, and more variables to represent the characteristic of traumatic head injury patient in the province of Bali. Thank you very much for your attention.
Thank you very much for Dr. Wayan for your great presentation. I think now we are going to our last speaker. Dr. Hendrikus, are you monitor now in here?
Yes, I am.
Okay, thank you so much. So you want to live presentation or recorded or pre-recorded video?
Yeah, I'm sorry because I can present my presentation live because I am in some preparation for operation, so I think we'll be okay to present my presentation by recorded presentation. Thank you.
Oh, okay, thank you. Committee, do you have the pre-recorded video for Dr. Hendrikus?
Good afternoon, ladies and gentlemen.
Thank you.
First, I would like to say thank you for the Committee of Second Asian Congress of Neurological Surgeons that give me the opportunity to present our works about the management of depressed skull fracture after alcohol intoxication in the era of COVID-19 pandemic at Papua, Indonesia. I am Hendrikus Masangbanboli from Neurosurgery Division, Department of Surgery, Faculty of Medicine, Cenderawasih University, and Abepura Hospital, Papua. As we know that traumatic brain injury is one of leading causes of death and long-term disability in young people less than 40 years. This mostly causes injury to the brain parenchyma with subsequent high risk of CNS infection, convulsions, and deaths. In general, about 35 to 81% of traumatic brain injury patients are due to alcohol intoxication. As we know that today, the incidence of COVID-19 new cases increased in Papua, and this condition changed the trauma patient assessment and management in emergency and operating room as well. For your information, the neurosurgical service in our hospital just started by November 2020. And alcohol intoxication is a major predisposing factor in traumatic brain injury. And also this consumption of alcohol also known to be a risk factor for death in TBI patients. Alcohol concentration was detected in 35 to 50% of patients diagnosed with traumatic brain injury who had previously consumed alcohol. Here, we report some cases of depressed skull fractures after alcohol intoxication in period of 6 months that we managed in our hospital in the era of pandemic COVID-19. For the strong recommendation to perform the craniectomy debridement and elevation of grossly contaminated compound depressed cranial fractures as soon as possible after the injury. And today, COVID-19 pandemic caused by SARS-CoV-2 virus already changed the depressed skull fractures management in emergency room and delayed the operation procedure in operating room. This is the patient profile that we report in these serial cases. We report 10 patients come to our hospital with chief complaint decrease of consciousness. Some of the patients have depressed skull fractures, open depressed skull fractures, and 2 of them have closed depressed skull fractures. There is also some intracranial lesions variation in all patients. Some of them have cerebral tissue prolapse, epidural hemorrhage, intracerebral hemorrhage, and subdural hemorrhage as well. And after we perform the cardiac or cardiotomy debridement and elevation, we also follow up for the surgical site infection, and also there is no other complication when the patient went out from the hospital. In our area, consume the alcohol usually more dominant in the party, or for small group party or large party. And after that, the people usually ride their motorcycle and also have the motor vehicle accidents. And some of them also have small group conflicts actually, and they usually use the method like this in this picture to make the injury in the head of their partner in conflict. And after that, they will bring the patient directly to emergency room and ask for the help for to the doctor or the nurse in the emergency room. This is the management algorithm for open head wounds caused by MSH. We adopt this clinical algorithm and make some modification, especially in the era of pandemic COVID-19. After we make sure that patients have already clear for ABC steps, and we gone for the GCS, we have to perform the antigen test for SARS-CoV-2 actually to make sure if they have the result of reactive or non-reactive. If the result is reactive, so we have to continue to swab antigen test before we perform the head CT scan. This is why have to perform like this, because the for using the head CT scan machine, the it is obligatory to make the swab antigen test before the head CT scan. And after we get the result of head CT scan, we can perform the surgery with the continuous procedures in the operating room. So the challenges are we have delay in head CT scan due to the COVID-19 screening procedure, and the other challenge related to the family and patient sometimes afraid to when they hearing about the next plan to perform or underwent the neurosurgery procedure, because this is very rare procedure for them actually. To develop the clinical management algorithm like this, uh, we have some problems, especially delay problems before underwent the surgery procedure, because we have to make sure the status of the patient have to get the result of free from the SARS-CoV-2 infection before the head CT scan and before the surgery as well. And this pathway or this algorithm we developed at the very beginning in the first attack of the COVID-19 pandemic in our hospital. But today, we face the second wave of COVID-19 pandemic. We have more challenging related to the time, because at least we have more 2 days before we perform the surgery to wait the results of the PCR, because our regulatory hospital make the policy that before the patient enter the operating room, they have to make clear about the status of the patient based on the real-time PCR results. And after that, if they're free from the SARS-CoV-2 infections, we can perform the surgery. In operating room, we washing and scrubbing the patient for 30 minutes. We use the physiological natrium chloride with gentamicin 2 ampoules for the combination, and we also using the povidone iodine and hydrogen peroxide to washing and scrubbing the wound. If we found that there is dural tear, we will administrate the combination of antibiotics. More than one antibiotics consists of ceftriaxone 1 grams for 2 times and metronidazole 500 milligram for 3 times, combined with the phenytoin to 100 milligrams for 3 times. And our patient usually have 10 to 15 days hospitalization after the surgery. And for after the patient went home, we have to continue the oral antibiotic combined with cefixime and metronidazole for next 10 days before they visit the uh, polyclinic of neurosurgery after they went out from the hospital. We know that COVID-19 confirmation test is an obligatory before cranio or craniectomy procedure in our hospital. So the test provide the safety or for all person in operating room so that the doctors can help patient without worries about the risk of the transmission. So we sure that patient safety and doctor safety are both more important today. And related to alcohol intoxication as the risk factor for TBI in the era of pandemic COVID-19, we have to divide the pre-operative procedure steps to make sure the result of real-time PCR for COVID-19 and administrate the pre-operative antibiotics in emergency room, and also in the operative steps we continue to washing the wound with aseptic and antiseptic procedure, and also we using some combination of antibiotic, peroxide, hydroxide peroxide, hydrogen peroxide, and also in the post-operative step, we have to make optimal antibiotic administration, especially intravenous antibiotics. And related to the issue of surgical site infection, we also focus the follow-up and wound care. And for the last but more important thing also, we have to make sure the status of the nutritional intervention for the patient. So the patient refused to have prolonged hospitalization today because they were really afraid to the transmission risk in hospital, and prolonged hospitalization contribute to the increase the health costs. This is why we have to make more aggressive intravenous regimen of antibiotic to affect lower infection complication as well, because we have a prolonged procedure before the operating step. Another important thing, also we have to solve the issue related to the alcohol intoxication in the era of COVID-19. So we have to make more promotion and preventive strategy to prevent the traumatic brain injury related to alcohol intoxication. For the conclusion, patient safety and doctor safety are both important today, and alcohol intoxication has the potential to cause TBI in motor vehicle and machete assault victims, especially an open depressed skull fracture. Recording cases of traumatic brain injury due to alcohol intoxication like this are significant to contribute to the establishment of various policies and regulations related to alcohol consumption. Aggressive and prolonged administration of antibiotics are significant for delayed operative procedures of patients with an open depressed skull fractures. Thank you for your kind attention. If you have questions, you can make some discussion or email the question for me. Thank you very much.
Thank you very much, Dr. Hendrikus. I think this is our time in first session. I see there is a lot of question for Professor Valerie Fakin, I think. Professor, are you in still monitor? Please, yes, I think.
Yeah.
Because the time is very limited, Professor, maybe to answer, it is okay for you, to question for you?
Yeah, well, as many as you like. There were several questions to me. One from Dr. Glenn Tariana, and he's asking, did you continue giving neuro aid to the patients after the study was finished? Yes, we provided treatment with neuro aid for 6 months, and then we stopped it. But we followed up all study participants for the next 3 months and evaluated the effect, whether it carries over or stops. And for primary outcome, the effect continued. It was attenuated a little bit, but it continued. We also observed continuing positive effect, not only on complex attention, but also on executive functioning, and a little bit less to quality of life. Quality of life improved in both groups, placebo and neuro aid. The second question, did you do any follow-up? That's what I just answered. Regarding the study population, majority of the patients had mild TBI. Do you think it might contribute to your results? No, it did not contribute to our results because the groups were perfectly balanced for all important prognostic risk factors, and we evaluated the effect of neuro aid against placebo. So we cannot explain positive results by the mildness of TBI. Any thoughts on doing to a more severe TBI population? We have no evidence for that. We only had one moderate severity TBI, but it's quite possible that positive effect will be applicable to the more severe TBI. It just needs more evidence for that. And 2 more questions if the time allows. Is it all right?
I think Dr. Adi is okay, I think.
Okay.
Yeah, Dr. Terry, I think it's no problem with it.
Okay.
Yes,
Is there a long-term study on the chronic effect, both advantageous and disadvantageous ones regarding the use of neuro aid on TBI? Not in our study, we did not follow up, we did not have funding for that. But I think in other populations, like stroke population, MOLEC have a very long follow-up period that showed that the positive effect of neuro aid continues over a longer period of time. If there are long-term study on the chronic effect regarding the use of neuro aid, that just I answered that question. So if there is any other questions, oh yes, there is another one. Is there any difference outcome given neuro aid between the patients with and without intracranial lesions? We did not have patients with intracranial lesions. All our patients, most of them were mild TBI, and I think the effect of neuro aid is particularly important for axonic injury. That's mild switching of the neurons along the axis. That probably accounts for most of it, of the positive effect.
Yes, thank you, Professor. I think the time is end. Oh, Dr. Hadi, the committee is want to ask to you, Professor.
Professor, in the chat box, one question from the Descartes, maybe about the has neuro aid drug interaction been investigated yet?
Yes, we did record other medications the patients took at the time of the intervention. We did not find any interactions. It was perfectly tolerated by all patients. And in fact, there were more side effects in placebo group than in Neuro 8 group.
Professor, maybe in our experience in Indonesia, same maybe with the Dr. Teddy, many patients with traumatic brain injury in Indonesia in 4 patient. We know about Neuro 8 is more expensive. I think is ideally is 3 times is 2 tablet is more expensive until 6 months. Maybe it is problem in Indonesia. And our experience, because in assurance is not cannot do the coverage, and it patient with the maybe have some money to buy the Neuro 8, but it's not the totally with the strict dose for the coverage. It is my experience, but we must in maybe if a patient with the indicate to the operate, we must operate. After that, we support it to the neuroregeneration and neuroprotective effect for the Neuro 8. But patient with the have buy the Neuro 8 maybe. This is my experience. I think Dr. Teddy maybe some.
It's a good question. It is quite expensive drug, as you know. But there were observations of lesser dosage, not 2 pills 3 times, 1 pill 3 times, and the effect are very comparable. So I think in the situation of financial constraints, 1 pill 3 times is acceptable.
Yes, and I have one patient with the pediatric and young patient maybe is more different with the standard treatment if we combine with the Neuro 8 after surgery maybe with in clinical experience.
Yes, there are accumulated anecdotal cases that it works in pediatric patients as well. I heard many presentations about that, but again, there were no a particular trial in pediatric population. There is another question. Neuro 8 is mainly herbal, consists of many extracts. What component do you think most? I cannot answer that question. That's the situation with all supplements. They are multi-component, and to separate effect of a particular component from effect of other components is not possible, really. They all work in combination.
Yes, thank you so much, Professor. I think the same in Surabaya, Dr. Hadi, we have the same problem, but there is a lot of patients that can afford Neuro 8. So for the patient that can afford Neuro 8, we will give them the Neuro 8 for neurodegenerative, I think. But you know, in our you know where is I think Dr. Hadi know where is the place that we cannot buy Neuro 8 like that. I think okay. Thank you. This is from committee. The time is up, so I will give our session again to our host. So thank you so much for all participants, and thank you so much for all our honorable speaker. Thank you for this very interesting session 1. Host, I give it to you again. Thank you so much.
Thank you,
Professor. Good
Thank
afternoon.
you.
Thank you, Prof. Valerie, Dr. Teddy, and
All the best. Thank you.
Thank you for all the participants, Prof, Doctor. Maybe before we close, we can take some picture. Please open the camera for all participants. Okay. On my mark. 1, 2, 3. Okay, once again. 1, 2, 3. Okay. Thank you. See you later.
Assalamualaikum warahmatullahi wabarakatuh. Good
Waalaikumsalam.
afternoon to all participants. Welcome to the second ASEAN Congress of Neurological Surgeons 2021 Symposium. Now we will join to the second trauma satellite session. The session will be led by Dr. Rohadi, MD, PhD. Let me introduce our moderator first. Please welcome Dr. Rohadi, MD, PhD. Good afternoon, Doctor.
Afternoon, Dr. Basit. Thank you very much.
Okay, Dr. Rohadi, MD, PhD is a neurosurgeon in West Nusa Tenggara General Hospital, and Dr. Rohadi is Vice Dean for Student Affairs at Faculty of Medicine at University of Mataram, and also a lecturer of Faculty of Medicine, University of Mataram. Dr. Rohadi graduated from medical school at Udayana University, Bali, then continued his neurosurgery residency at Erlangga University, Surabaya, and graduated from a doctoral program at the Hasanuddin University Medical Faculty in Makassar. Okay, Doctor, please, the session is yours to present. Thank you.
Thank you, Dr. Basit, for your introduction about the trauma session 2. Now we continue to the second session for the trauma in the today. In the session, we have 6 speakers from the Indonesian and other country. First, Dr. Teddy Apriawan. Second, my senior, our senior, Dr. Eko Prastio, PhD, Dr. Third speaker, Dr. Muhammad Fadli Said from the Sulawesi, and Dr. Novat Krishno Aji from Jember, and Dr. Kavin Kadevani from India, and the end session with Dr. Thomas Tommy from Indonesia. Maybe we can for CP. First speaker, Dr. Teddy. Dr. Teddy is my senior from the Surabaya General Hospital, Erlangga University. Is a senior in the trauma consultant in the Sutomo. For Dr. Teddy, time is yours, please. Every speaker maybe is 15 minutes. Yes.
I have
Your live or recording, sir?
recording, I think.
Okay. Some speaker with not clearly in recording. Okay. Please, committee. With the title is the use of medical 3D printer from the reconstruction and preoperative planning for neurosurgery is
in developing country, especially in our country, Indonesia. The title is about to make an innovation in the field of neurotrauma education. And as we can see in here, for my first presentation, there is I make some red line in here, non-COVID era and COVID era. In 2018, we can see that our center in Surabaya, especially Sutomo Hospital, we have approximately 631 patients. In 2019, increased 711 in 1 year. And for the number of operations, 248, and in 2019, 206. But in the after the red line, in the COVID area, we can see in here 2020, the number is decreased approximately until 75%. The number of patients that came to our hospital is decreased. Then the number of operations is decreased too. In the number is 115. And now in July 2021, 47 months from January 2021 and until July 2021, the number of our patient in trauma is very, very small, only 85, and the number of operations only 55. In 7 months, we have only 55 patient in trauma that indicated in operation, And if we try to make in 1 month, maybe our operation only 5 until 6 patients, 5 until 7 patients in 1 month. This is a very small amount for us, and that's why I try to make this title, this title as my main presentation. So in the future, we can predict that what we have to do for our resident to have their competency skills as a resident of neurosurgery. So in this pandemic COVID-19 era for these 2 years, our education method must be changed. This is due to a decrease in the number of patients, as you can see at my previous slideshow, who come to our center is very decreased. And we have a strict protocols that we have to obey due to a very high infection. We must make a new innovation for our education, especially in our teaching hospital in Surabaya. So what can I give to you, or maybe some information that to educate our neurosurgery resident in our center, especially in Surabaya, Indonesia, East Java, there are several things that must be given to them, including the first one is knowledge. The second one, soft and motoric skills, technique. The third one is method of operation. These three is, I think, is very, very important to make our neurosurgeon, to make our resident in our center to be a good neurosurgeon specialist. For knowledge, I think we all know this. This is common for this 1.5 years before that. In this pandemic era, the transfers for knowledge have been changed in worldwide. There is an online media that help all of us to transfer our knowledge for resident. And with this online media, we can make various kind of teaching to resident. Maybe the first one, long case discussion, weekly report, trauma class matter like that I presented now, textbook reading routine, new trauma weekly forum, and maybe battle text discussion. And this transfers of knowledge, I think, is going smoothly and very good, that we can give our knowledge to our student or our resident with online media. Until now, we still use a media online. But for the soft and motoric skill, this is a problem for us. That you can see in here, the number of our patient is very small. But don't worry, I still contact my postgraduate student as a neurosurgeon specialist in another city, in another island. They said that 70% until 90% the patient that they treat is a neurotrauma patient. So this is a problem for our center, that we have to change the method of our technique to teach our resident. Maybe the bold letter in here, medical simulator, have a time or maybe have a chance to make our education more good enough, or maybe near enough to become to make our resident have their competency in neurosurgeon. Medical simulator, they have virtual reality, they have augmented reality, and they have mixed reality. So a medical simulator, these three, one, virtual reality, augmented reality, and mixed reality, if we try to make a multi-simultan training in our resident, maybe it can help them to reduce their malpractice, because we give them the skill and the motoric with this modality medical simulator. And as we know, it can increase our effectivity and efficiency in medical health service. So now medical simulator like virtual reality, augmented reality, and mixed reality, there is a lot in country that have a good technology, but not in Indonesia. So now is the time for us to try to make some innovation in this medical simulator. So what is the advantage, or maybe a different between the conventional and virtual reality? Like this recital that I make for you, the first one, no patient involvement, yes or green in virtual reality, and conventional, no. The second one is no need additional operation room, yes, in virtual reality, conventional, no. Reduce cost, yes, in virtual reality, no in conventional. You can see in the graph, in the table in the right side, in here, live exercise. And we try to compare with virtual reality, live exercise. In the year one, you need a lot of money, $76,000. In the second one, in the second years, you need approximately $76,000. In the third year, you need $76,000. How about virtual reality? You can see, yes, the cost in the first one, in the first years, is $109,000, approximately $109,000. But in the second years, only $3,000. And the third year, only $3,000. If you make a cumulative cost in the end of the third years, the cumulative cost for virtuality is more cheap, I think. Yeah, is more cheap, or is not expensive if we try to make a comparison with the live exercise. As we know, in the live exercise, maybe like in my time when I'm resident, or in my time as a young neurosurgeon, we usually held some cadaver dissection like that. It is not a very cheap cadaver, I think. It is need money, it is need time. The instrument for the operation, we need to bring it from our center to the place that we held the seminar or the workshop, and it need a lot of time and it need a lot of money. But in this if we try to make an innovation in education, maybe virtual reality is the answer for us in the future. So this is our step, maybe one of the steps to make a virtual reality. We call it shadowing. Shadowing is how to bring our team, in this case maybe our engineer, medical engineer, to bring them in our operation room to see the real operation, so that they can feel, oh, like this is the operation, this is the operation that the neurosurgeon do in their real life. Because with shadowing, like in the left side, it is a real picture, and the left side, it is maybe a graphic picture that the engineer made. And because we need a cooperation between the neurosurgeon and the medical engineering. And then another step, maybe the other step, is user interface. This is how the conceptor or maybe the engineer try to make the same perception with our resident. We try to communicate, we try to make a perfect combination that maybe in the future this application or this virtuality will become real and help us. Maybe the education in Surabaya, one of the education to graduate from our center is by virtual reality. This is the model that we try to make. Maybe in the future, we have a tool and instrument in the left side and the right side. We have the doll head, maybe, and is presented the brain, and we have the visual with video, and maybe if you want, we can use augmented reality using in our eyes. Still in progress, but we hope that this will be our innovation in trauma. And the third one that I want to give to you is the method of operation. Some of the things that we can innovate is the method of operation. For these 2 years, our center is focused in the method of cranioplasty because we want to make it even better, both in the term of time, in the term of price, cosmetic, and education. The other innovation is how do we educate the president about anatomy for real case by using 3D printing pre-operative planning. That must be, as a neurosurgeon, that traumatic brain injury, if the patient came to us, there will be a conservative treatment or operation treatment. In operation treatment, maybe it depends on the operator. Maybe the operator put the bone back, or maybe the operator will preserve the bone, maybe in abdomen, or maybe in subgaleal, or freezing with minus 10 or minus 15 Celsius degree, or they will not preserve, or they will not put back. Maybe is infection bone or the other, we don't know, but I think 3 of this is very important in operation. And 2 that I make a red circle. This is that I want to present it in this presentation. As we know that in cranioplasty, 3D cranioplasty, there is a lot journal. There is so much journal that talk about it. Every country have their different technique. Every country have their different method. But the goal of all this country is to make a better cosmetic and maybe affordable price for the patient, because we are in the developing countries. Low middle Indonesia is in the low middle income, and the last one, the news said we are now in the low income country. Now this is time for us to make a 3D cranioplasty that can be afforded by the patient. As you know, in Indonesia still use manual cast. Using our hand, we try to make a manual cast, but I think this is different between one operator and the other operator. They have different hand. My hand is very little, but maybe the other operator have a big hand, and the size, the form, and the counter will be different from one operator and the other operator. So maybe we try to see that how we can make 3D cranioplasty, especially in low middle income country, higher cost but better result. No, in my perception that we have to make low cost but in the better result. So that is our goals in developing countries. Now Indonesia must change the protocols. Manually cast must be changed into computer-aided design, because we want a perfect counter and surface, because we want a maximal fitting from defect. And the third one, maybe we want to affordable price for a cranioplasty 3 dimension. This is a journal that we try to make about a three-dimensional painting customization, only a case report. But in here, we, with our team in IDIC, Integrated Digital Research Center, we can make a printing scheme, how we prepare our patient. The first one is we make a CT scan 3D reconstruction. We can collaborate with the radiographer, and we have the decom image after that from the radiographer. After that, we bring it to our team, Integrated Digital, for make a materials mimic, then will be translated to flash print, and the machine that we use is flash forward guided to S. And the material is PLA, polylactic acid, and in here we will have a negative mold and 3D craniofacial model like this. So this is the 3D cranial model that we can give to the patient or the family from the patient, and I think they will happy that they see that, oh, like this is my skull defect, and this is the negative molding. With this, we can make a perfect fitting for this skull defect. This is very simple how we make a methyl methacrylate or acrylic for the patient, but in the end, in the picture number 8, we can see in here that it is perfectly nice contour and nice form, and I think the shape is smooth enough. So I think advantage for 3D cranioplasty is the first one from the price is affordable for developing countries, especially in Indonesia. For the duration at operating theater is more faster because the operator will be open the skin, incise the skin, and the assistant operator will mold the acrylic to make the cranioplasty acrylic same time with the operator. So this two operator will be, one operator and one assistant operator will be work together in the same time, and the time is more shorter and faster. For the cosmetic, we can see in my previous slide that better than manual molding. For education, yes, it will be provide a new technique for our resident, especially our center in Surabaya. After that, we try to make collaboration with another center. This is a patient from Armenia. They have their machine for 3D titanium printing, but they need a discussion, they need a collaboration about the design. Eventually, we have our professional team to make a design, and they have a lot of experience to make the cranioplasty is very fit in the skull defect. This is our result. Our collaboration Indonesia and Armenia country. This is the patient, and this is the titanium plate that they print in their country. But we give them the picture. We make for them the design. So I think it is very important to learn each other and exchange knowledge. This is their center in Armenia. As you can see in here, this is the sign from Indonesia, but the printed in Armenia. So I think the exchange knowledge in another center and between country, I think is very important, because in here, maybe in the future, we can learn too from them. So another topic is 3D printed for operative planning. This is a case that we have in our center. 18 years old man with a penetrating brain injury of wood. This is from our affiliated hospital in Mojokerto. They perform CT scan without contrast and show that there is a wooden traumatic brain injury, transorbital, 11 centimeter from left medial orbital to superior part. And after that, the patient is referred to our center, and we make CTA, and we make MRA, magnetic resonance angiography, and we make a magnetic resonance venography to refer that there is no lesion on internal carotid artery or maybe in sinus cavernosus. And after that, this is the result for the MRI, MRA, and CT scan. As you can see in the CT scan on the left side, for wooden, I think what we can see, the image cannot give us a good image about size, the form of the wood, because you can see in here, we only can see an image of hypodense like air. Like air is very black in here, but we cannot see how is the size and form. And CT 3D at the time is not performed in our affiliated hospital. So after that, we make an MR angio. In here, yes, we can see our artery in here. In MR angiography, there is no rupture in our artery. But where is the wooden? We cannot see the wood. In here, MR angio cannot see the wood. So what we have to do? Maybe for the expert specialist, yes, we can predict and we can make an image in our brain. It's okay. But how about our resident? Can they do like us? Not yet, because I think they need time step to learn. Time steps to learn how to make an image of CT scan and MRI in their brain. So I think this is a very important that maybe 3D printed penetrating brain injury can use for the tools to educate our medical student or resident. In here, it is very clearly that you can see this wooden that penetrate in the transorbital. This is the wood, and this is the sinus cavernosus. But I think for the ICA is still intact and there is no rupture. So for take-home message, that the first one that we can give to audience, that the educational innovation in the field of neurotrauma is still needed in this pandemic area and the future ahead. Number two is cooperation with related specialists, especially engineering expert, must be accompanied by the same spirit and intention. We must work together to have our goals. Number three, we must be able to provide appropriate skill compensation to our neurosurgery resident in every way we can, because this pandemic era in Indonesia now, especially in this June 2021 and July 2021, we cannot predict. We cannot predict because the number of the patient is increased, and 90% of the patient in our emergency ward is COVID patient, not neurotrauma patient. So this is the time for us as a teacher and the time for us to make some new way to give education to our residents. I thank you to all my team, especially our team that help us to make this happen. But I think our goal is still far from reality, but it's in progress. 50% is in progress, and I hope that our goals will be dream come true, and maybe in the future we can make our resident will be have a lot of competency in neurotrauma patient. Thank you very much. Thank you for this opportunity. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Teddy. Nice presentation. This is a new technique and new innovation maybe in the Indonesia for the 3D format for the cranioplasty. Second speaker, next session is the Eko Prasetyo, MD, PhD. He is our senior. He's associate professor of neurosurgery in Department of Neurosurgery, School of Medicine, University of Samratulangi, Indonesia. Current position now, he is head of Department Surgery, Samratulangi University Medical School, and head of Neurosurgery Division, Department of Neurosurgery, Samratulangi University of Medical School, Kando Hospital, Manado. Head Neurosurgery Department and Siloam Hospital, Manado, Indonesia. Head Neuroscience Department, Sentra Medical Hospital International, North Minahasa, Indonesia. Professor Eka, are you ready? Yeah, you presented with the recorder or
yes,
live?
Yes, thank you, Dr. Hadi, and thank you. Good afternoon to all speakers.
Yeah, the title of Dr. Eko is Traumatic Brain Injury and Neuroplasticity. Maybe it's an interesting topic, sir.
Yes.
Time is yours.
Okay, please show the recording to our presentation that I prepare and send to the committee.
Okay, committee.
Good afternoon, dear moderators and all participants in this meeting. Now we present an address with the topic TBI and neuroplasticity. No disclosure. Until a few decades ago, the neuroscientific dogma on the unchangeable human nervous system was common except for degenerative processes, and TBI neuroplasticity, an infinite journey, is alike as we explore the universe. The term neuronal plasticity was already used by the father of neuroscience, Santiago Ramon y Cajal, who described non-pathological change in the structures of adult brains. Kramer et al. Neuroplasticity has been defined as the ability of the nervous system to respond to intrinsic and extrinsic stimuli by recognized connectivity, structures, and function. Wheelock and Nikolic presented pathomechanism of neuroplasticity are cell function and neuroanatomy repair. JC and Watt described that neuroplasticity was component of neuroprotective and neuroregenerative. Meanwhile, we remind that neuroinflammation is the key factor of pathomechanism of secondary traumatic brain injury. It's clear that neuroinflammation is a process that must be overcome in order for the neuroplasticity process to take place properly. Let me see the slide. It's clear how the neuroinflammation important is. As we know, neuroplasticity has been studied simultaneously in secondary traumatic brain injury. NVU or neurovascular unit is targeting place in the brain inside. The location of damage to the brain tissue actually start from complicated process that occurs in the NVU, or rather the blood-brain barrier and the extracellular matrix, or we call it ECM. One of those important elements is blood-brain barrier. Interconnection of NVU is an important link to support neuroplasticity. In few decades ago, paradigm of neuroplasticity stated that switching important rules from neurons to matrix is a part of NVU, which we call metric-centric. There are three-level scale of network brain organizations. The first, micro scale, the level of individual neuron and synapses. Second, mesoscale, the level of neuronal groups and populations. And the end, macro scale, which is the level of anatomical region and inter-region pathways. How to support neuroplasticity and TBI? So we should maintain support to restore brain homeostasis, create an optimal microenvironment, and there is a link to support, as we said, yes, the important how to protect blood-brain barrier and all structures of NVU. Whereas on the other side, the brain is high energy organ. Protein kinase signal cascade in CNS trauma is the majority of the pathway. Kinase cascade mostly affect in MPP9 signal, a modulator nucleofactor kappa beta during transcription and translation processes. As we know, the MPS and HMGB1 stimulate initial process of neuroinflammation in this mechanism. Our college also defined as MGB1 is one potent modulator in those processes. Congrats to Dr. Tommy. NVU and blood-brain barrier is entry point all those mechanisms. We had published our research that component of NVU, which we call laminin, is a material of the NVU or ECM that affects to the outcome of TBI. As we stated earlier, that the neuroinflammatory process is an important part of brain damage. In that process, it is known that microglia as resident glial cells that are very influential in neuroinflammatory process. Yes, we know microglia in TBI. There is the good and the bad. There are two phenotypes of microglia, M1 and M2. M1 acts as pro-inflammatory control, and otherwise M2 is anti-inflammatory or brain recovery repair support. Clinical aspect. TBIs are multifactorial and multi-pathways. So we need golden bullet or bulk therapy. Yes, the golden bullet in the treatment of acute TBI has not yet been determined. While in the past decade, our understanding of the cellular and molecular change that occur after TBI has significantly increased. A number of new potential therapeutic targets has been identified that may be enable prevention of the onset of reduction of the extent of secondary traumatic brain injury. What is that said? Is it APO? Is golden bullet? It's okay. Surgical approach. Or non-surgical approach, sometimes surgery solely is not adequate. We should need neuropharmacology or other treatment modality. Floor handicaps, preclinical research are inadequate understanding of secondary traumatic brain injury, insufficient preclinical testing, lack of true investigation of pharmacokinetic and concentration drug investigation, value to adequate of therapeutic window, lack animal model, heterogeneous patient population, inadequate sample size, lack of power, and also inadequate functional outcome measurement. Yes, there are several studies showing neuropharmacology of TBI, such as PPR and minocycline, and several research of MLC 901, increasing neurogenesis and inhibit neuroinflammation. Congrats to Dr. Hadi, and also keep the potent to decrease peripheral level, so directly to protect neuroinflammation process. And congrats to Dr. Lisa Anzori, harnessing neuroplasticity, modern approach for clinical future. You see, immunization for the next change. And we know that hypothermia, deep brain stimulation, repetitive transcranial magnetic stimulation is promising for the next change. As we mentioned before that, the brain is high energy organ. Hypothermia, even though it's still pro and controversies, had a prospect to be explored further. The mechanism and action of hypothermic therapy, yes, it's like a bulk therapy, which is expected to reach many paths of TBI. We had published our research that hypothermia therapy could reduce mortality in severe traumatic brain injury patients. As like as hypothermia therapy, hyperbaric oxygen therapy, which is expected to be a mainstay like hypothermia therapy as a bulk therapy and TBI. We just published our research had concluded that hyperbaric oxygen therapy decreases MPP9 and effectively to relieve post-concussion syndrome. Park et al. Presented efficacy of the therapeutic strategy of severe traumatic brain injury, which was called all-in-one. Yes, we know surgery, non-surgery, barbiturate therapy, hypothermia therapy, and ICP management. It's all. As we know, we treated TBI in multidisciplinary approach. we keep still journey to the universe of neuroplasticity phenomena and mechanisms continue to expand, and multiple growing points associated with different areas of biochemistry, molecular biology, and molecular genetics, and turning to powerful branches. Unfinite path with mastery. Research on TBI should be further encouraged and integrated. Take home message. Neuroplasticity and TBI, the key factor is neuroinflammation, which multi-pathway, the entry point in NVU, the component of neuroprotective and regenerative. Thank you very much. Bless you all.
Thank you, Prof. Eko, for your nice presentation about the neuroplasticity and traumatic brain injury. I think we must continue with the third speaker, Dr. Muhammad Fadli Said from Indonesia. He is a neurosurgeon staff in Sawer Regarding Hospital, Palopo City. And now he is a young lecturer at neurosurgery department in Hasanuddin University, and he is a doctoral student now in the Hasanuddin University, Makassar. And with the title Effect of Erythropoietin Administration on Expression of Messenger RNA Brain-Derived Neurotropic Factor, Stromal Cell-Derived Factor 1, and Neuron-Specific enolase level in traumatic brain injury, systematic review. To Dr. Fadli Said, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for Dr. Hadi and the committee. I just have a short presentation for today, and please show my pre-recorded video that I have already sent to the committee. Thank you.
Dr. Basit.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon. Today, I will present my presentation with the topic effect of erythropoietin administration in the outcome of traumatic brain injury, a mini review. So, introduction. This review discusses the possibility that the therapeutic effects of erythropoietin or EPO may affect neurological function, neurological performance, and neurological recovery. Research over the last few years has clearly shown that erythropoietin is a strong promoter of neuronal survival. Administration of exogenous EPO in rodent trials provides neuroprotection after cerebral ischemia, traumatic brain injury, and spinal cord injury. Several mechanisms may mediate the neuroprotection with EPO, including decreased levels of inflammation, activation of kinase pathway, and via apoptosis genes. Administration of exogenous EPO with short interval after TBI hopefully could increase vascular endothelial growth factor. EPO and mRNA-BDNF may be direct contributors to angiogenesis and neurogenesis associated with brain repair. In the several journals, we compare the mechanism, the administration, and the result of activity of EPO administration. The first by Mahmoud et al. In 2007, treatment of traumatic brain injury in rats with erythropoietin and carbamylated erythropoietin. They use EPO injection around 5,000 units per kilogram intraparenterally and performs in 6 or 24 hours after TBI. And the result, post TBI after 6 and 24 hours significantly increase BDNF expression and improve spatial learning at 5 weeks after injury in mice. And the second, the effect of erythropoietin on reducing brain damage and improving functional outcome after traumatic brain injury in mice. They use a recombinant human EPO with the same dose with before was administered intraparenterally at 6 hours and at 3 and 7 days post TBI. The result showing that recombinant human EPO initiated 6 hours post TBI provided neuroprotection by reduction lesion volume as well as neurorestoration by increasing neurogenesis, then enhancing sensorimotor function and spatial learning. The third, erythropoietin protects primary hippocampal neuron, increasing the expression of brain-derived neurotransmitter. They use one dose intracerebroventricular injection, 100 unit per kilogram body weight, and the result is showing that recombinant human EPO significantly increase BDNF mRNA after 1 hour, further increase up to 4 hours and 18 hours of recombinant EPO treatment dose BDNF protein levels. Next, the effect of erythropoietin on spatial memory and entorhinal cerebrocortical level of BDNF in rat model of intrauterine growth restriction. They use subcutaneous injection of EPO in dose of 500, 1000, and 2000 international unit per kilogram until they are born in neonates. The result showing a significant reduction was observed in spatial memory. EPO treatment improves spatial memory by increasing BDNF levels in entorhinal cortex. Next, recombinant human EPO improve functional recovery in patients with severe traumatic brain injury, a randomized double-blind and controlled trial by Lee, ZM, et al. In 2016. They use EPO injection at daily dose of 100 unit per kilogram, average 6,000 units subcutaneously. On the first day, within 2 hours. On the third, 6th, 9th, and 12th days after admission. The result showing the serum protein level of NSA and S100 were lower in patients treated with EPO. This result suggests that EPO offers some neuroprotective effect and improve functional outcomes in patients with severe traumatic brain injury. And the last, effect of erythropoietin on serum NSA and S100B levels in neonates with hypoxic ischemic encephalopathy. They use EPO injection around 200 international unit per kilogram body weight intravenously from day 2 after birth to 7 days. And the result showing the serum NSA level on the 9th day after birth were significantly lower than the first day after birth in all 3 groups after. So the discussion in the table above, we can see that EPO given 6 hours or a short time after TBI will reduce brain damage and promotes functional recovery. This suggests that the therapeutic time window may not be limited to the initial hours after TBI. However, the optimal EPO dosage, dose intervals, and dosage amount to reduce brain injury and promote neuronal recovery after TBI have not been fully studied. In the above studies, the doses of EPO used to treat TBI were much higher than those used to correct anemia. And then neuroprotective effects of systemic or intracranial EPO suggest that a sufficient amount of exogenous EPO crosses the blood-brain barrier to provide a direct neuroprotective effect, or exogenous EPO acts on the other side of the blood-brain barrier and provided neuroprotection through indirect neuroprotection mechanism. EPO treatment is reported to have the effect of increasing MRA, BDNF, and reduce neuron-specific analysis expression in the brain. mRNA, BDNF can help neurons survive and stimulate new growth and synapse. The main finding of the recent study are that EPO has been proved to stimulate hematopoiesis and processes neuroprotective and neurogenerative effects through reduction of apoptosis, relief inflammation, oxidative stress, and excitotoxicity. But controversially, the impact of EPO therapy and mortality and long-term functional outcomes following severe traumatic injury is yet to be determined, as well as the optimal dose and duration of EPO therapy in patients with traumatic brain injuries are yet to be determined. As a conclusion, we know that increasing the EPO dose was necessary for optimal protection against brain injury in order for EPO to cross the blood-brain barrier. The second, the effectiveness of EPO in the activation of neuronal survival or anti-inflammatory neural differentiation and anti-apoptosis, which affect several biomarkers of traumatic brain injury. And last, EPO, given the significant effect of neuroprotective function following systemic administration. Thank you.
Thank you, Dr. Fadli Said, about your presentation with the title relation about the erythropoietin with the traumatic brain injury. Good presentation.
Thank you, Dr.
And
Ali.
we maybe for discussion in the last session, we must continue to the first speaker. He is name is Dr. Novan Krisno Aji. Is a clinical lecturer from the Jember Medical Faculty of Jember University, Dr. Subandi Hospital, General Hospital from Jember. With the title is Extraction of Gunshot Corpus Alienum in Upper Cervical Spine with the Transoral Approach, case report. For Dr. Novan, time is yours.
Yes, thank you, Dr. Adi. Assalamualaikum warahmatullahi wabarakatuh. I will share the screen.
Yes, you is a co-host. Yeah, you can share.
Okay. Yes. Okay. I will present my case: extraction of gunshot corpus alienum in upper cervical spine with transoral approach report. This is my introduction. One of the most causes of spinal cord injury is penetrating trauma. The penetrating trauma is caused by stabbing injury with knife, missile, or gunshot. The gunshot injuries have been reported as penetrating trauma cause spinal cord injury about 17 to 21%. And the surgery of spine trauma is challenging because the complexity of the neurovascular structure. This is anatomy consideration. To approach for the upper cervical spine, we can use two approaches from the nasal region and the oral region. If we use the oral region, we can see this anatomy of the oral region. To access the upper cervical region in the nasopharynx side, we could see that the tongue and the uvula and the soft palate will block our visual axis. So we must do the to get the good visual access. After if we want to go in the upper septal region to access the dura or the myelum, the C1, after we the mucus and we extract the mucus and the muscle, we encounter the ligament and the bone of the upper region. It is a very challenging approach for the transoral region. Okay, it is the diagram how we make a gunshot wound of the spine. If we got a gunshot wound on the spine, we use the ATLS protocol, the AC. We see the hemodynamic stabilization. If the hemodynamic is unstable, the emergency cases, we do the operation in emergency case. If the hemodynamic is stable, treat the wound. Do not try to take the bullet or the aluminium corpus in the outside the operating theater. Use the broad spectrum antibiotics. After that, take a detailed theory about the bullet fire, distance of which they are fired, and examine the neurologic function. After that, do the photo, do the radiological investigation. If the spine is unstable, do emergency surgery, fusion of the spine. If there is a stable spine, try to take a 5 point. First, if there is any progressive neurological deterioration. Second, if there is any persistent CSF fistula. And the third, there is any to the nerve root compression. The fourth, if there is any bullet migration. And the fifth, if there is any bullet in the lumbar canal causing the cauda equina syndrome. If there is yes, do a surgery. Laminectomy and fusion. If you can took the bullet, if not, just do the laminectomy to decompress. If you find any, you cannot find any, just observe the patient. This is my case, a 53-year-old man got a gunshot in the maxillary region of the face. The patient is taken care by the general surgery. After got the photo, they consult to me. After I examine the patient in KCS is 15, the vital sign are with the normal limits. The inspection of the neck and spine region with the normal limits, no inflammation, no CSF leakage. The sensory and motorics intact. He just got a pain sensation in his throat. He got shot in the face. The pain is also in the throat. It is my clinical consideration. Why do I operate this patient? In this, if that in the diagram, you can see observe the patient, but this is my consideration. The first, every bullet that comes from a gunfire considered sterile because the heat after they shot the gunfire, the heat will sterilize the bullet. In my case, the wind rifle bullet is not sterile, no heat in that. And this bullet travel from the nose, the maxillary sinus, and until the soft tissue, the entire the C1. The microorganism will adhere to the bullet, and the bullet will create an inflammation reaction and could disturb integrity of anterior cervical. And to know that bullet will travel more or displace, so I did the operation. This is the X-ray photo. You can see this is the entry wound of the bullet. There is still a small chunk of the bullet in the maxillary region, and this small chunk in the bony structure of the skull base. And this is a big chunk of the bullet in the left side of C1 anterior. You can see very in detail in the CT scan. In the axial photo, the bullet is in the left side, in the anterior at C1 arc. This is consideration what approach we could use the transnasal endoscopic approach in the nose until the nasopharyngeal region, or we use the transorally with microscope or endoscope. My decision, I use the transorally because I don't have the endoscope. Then I performed the transoral microscopic evacuation of the bullet. This surgical procedure should perform an appropriate technique with minimal complication. Then transoral approach can assess the craniovertebral junction areas anterior arc of C1. The advantage is minimal damage and the causing surgical complication. This is the intraoperative video. I put the patient in the extension of the head and fixate the head with the head frame. So my microscope is good, very look in the nasopharynx region in the upper cervical spine in C1. I used a special retractor. Retractor is usually used by the mouth surgeon, and the anesthesis is intubate this patient the nasopharyngeal way and put the tube in the right side because the bullet in the left side. And in the left nostril, I put the nasopharyngeal tube and I attach it in the uvula. After that, I retract the tube. Like that. This is the nasopharyngeal tube. I attach it in the uvula. And I pull the nasopharyngeal tube. So, excuse me. So it visualized very good at the nasopharynx, and this is the upper cervical region in the C1. After that, I put the marker and shoot it with a C-arm to evaluate my position of the bullet, like that. After that, I dissect. This is my finger also dissect and palpate the bullet. After few minutes, I dissect the mucosa and the nasopharynx muscle. The bullet came through, and after a more extensive dissection, the bullet is completely visualized, and I'll pull out with my cocker. After that, I just suture it in the interrupted fashion and hemostasis. And this is the bullet. The bullet is typical of the wind rifle bullet. The apex is broader than the base of the bullet. After that, I evaluate this patient in the ICU. Now we have a ventilator. Day 3, I evaluate, and the patient is discharged in the day 4 after operation with full conscious and no deficit. For the discussion, gunshot injury to the spine cause the tissue damage in the spine as surrounding tissue. Velocity, mass, and shape, and composition of the bullet material should be assessed to determine the severity of trauma. Some type of a bullet, like the lead, could make intoxication of the lead for the patient. At my case, the bullet is from the iron. It's a low velocity, small blunt, metal composed by the iron. This type of bullet has direct injury with low comorbidity of incidence. In this patient, I managed the primary survey, assess there is no deficit, identify entry wound and exit wound in this region, expected any active bleeding or leakage. They know the direction of the corpus should be performed in the operating room, not in the ward, not in the emergency room, the operating room, because we don't know what can structure been damaged by this bullet. Gibbs has said that the observation rather than surgical removal does not increase the risk of infection, but it should be noted the possibility that the bullet will migrate that easily damage the surrounding structure. Surgical is necessary to remove the corpus callosum, but it should be noted that there is high possibility of neovascular injury and instability issue. Conclusion: this approach can be used as a method to extract the upper cervical spinal region without spinal cord tissue damage. This approach can be used safely and effectively expose the upper cervical spine and umbilical structure and is advanced by direct access, relatively simple operation, short operative time, quick recovery, reliable corrective effect, and few complications. Here's the patient after day 4. Did no pain, free of pain, and after evaluation, no instability issue. This is a good outcome. Thank you.
Thank you, Dr. Nopan. Nice cases for your center. It's rarely case maybe in the cervical after cervical.
Yes.
Maybe we must continue to the five speaker. Five speaker is Dr. Kavin Kadevani from India. He is now working as neurosurgery resident in LTMMC and Hospital of Mumbai with the education MBBS from the IMC Mid Medical College Ahmedabad, Gujarat, India, MS General Surgery in the BG Medical College in Civil Hospital Ahmedabad, Gujarat, India, and Magister of Chirurgy Neurosurgery in LTMMC and General Hospital in Mumbai, India, with the title Comparison of Prosthetic Value Between GCS and Auditory Epocate Potential in Head Injury Patient, an Institutional Prospective Study. Dr. Kavin, are you ready here?
Yes, hello. Good evening,
You
and I thank you for the opportunity you gave me to share our study with you.
Okay.
Committee, could you please play the pre-recorded video?
Oh, pre-recorded. Okay.
Yes.
Committee, please.
Hello, everyone. I am Dr. Kavin Devani, neurosurgery resident in Lokmanya Tilak Municipal General Hospital, Sion, Mumbai. Till date, a lot of subjective scales like Glasgow Coma scale are available to prognosticate patients of head injury. However, it was our endeavor to come up with something which is more accurate as well as objective to prognosticate patients of head injury. So we thought of using brainstem auditory evoked potential, which has already proved its worth to prognosticate patients of stroke, comatose patients, as well as patients with demyelinating disorder. We thought of comparing it with Glasgow Coma scale. So we conducted a cross-sectional study in 66 isolated head injury patients to compare the outcome derived from both brainstem auditory evoked potential with Glasgow Coma scale, and also to decide the efficacy of auditory evoked potential in head injury patients. We included patients between 10 to 50 years of age with acute and isolated head injury. All patients with systemic injury and illness were excluded, as well as patients with bleeding from ears and petrous bone fractures were excluded. After resuscitation and stabilization, all the patients were subjected to Glasgow Coma scale and auditory evoked potential evaluation simultaneously. According to the Glasgow Coma scale, they were categorized into 3 groups: mild, moderate, and severe. The ones with scores between 13 and 15 were categorized as mild head injury patients, with scores between 9 and 12 were categorized as moderate head injury patients, and the ones between 3 to 8 scores were categorized as severe head injury patients as per the convention. Auditory evoked potential, they are the recording of cortex activity which is induced by auditory stimulation. On stimulation by any sound impulse, 3 types of responses are obtained. Early responses which are obtained before 10 milliseconds, middle latency responses which are obtained between 10 and 50 milliseconds, and late responses which are obtained between 50 to 300 milliseconds. However, early responses is something which is of use and concern to us. Middle latency responses are no use, and late responses are of use to a neurophysician for checking the attention and for carrying a test like P300 or MMN mismatch. So we recorded all the early responses, which are actually very tiny potentials. The recording was done with taking into consideration the American Clinical Neurophysiological Society guidelines. A click stimulus. There are 3 types of stimulus: a click, tip, or a burst stimulus. However, we used a click stimulus, which is a monophasic stimulus, which is shown to give better responses. So we used a click stimulus of 65 decibels for 2 milliseconds with a frequency of 9 hertz via headphones. And 3 electrodes were placed, one on the middle forehead, one on the left forehead, and the left mastoid. The left mastoid being the ground electrode, and one over the middle forehead being the active electrode. On such stimulus, waves which are shown in the right bottom of the slides are obtained. There are 7 types of waves which are obtained by one stimulus. The first wave is the recording of an impulse going through a vestibulocochlear or 8th cranial nerve. The second one, which is obtained from the cochlear nerve. The third one is a response obtained from the superior olivary nucleus. The fourth one from the lateral lemniscus in the pons. The fifth wave is a response from the lateral lemniscus in the midbrain and also from the inferior colliculus. The sixth wave is the response which is obtained from medial geniculate body in the upper midbrain. And the seventh wave is the one which is obtained from primary auditory cortex. However, these waves are very difficult to interpret and also time consuming. So we use a method called as averaging, which is used to extract a revealed potential buried, and we use a monitor which works on autoregressive model with exogenous input or ARX model to calculate AEP values. These are auditory evoked potential values and they range from 0 to 90. Higher the AEP value, better is the consciousness of the patient. So they were classified into 3 groups. Group 1 with values more than 60, Group 2 with values falling between 31 to 59, and Group 3 with values less than 30. 66 patients, as said, were used in our study, out of which 40 of these patients survived and 26 succumbed. Below on the right bottom of the slide is the graphical presentation of patients who were categorized into mild, moderate, and severe, and number of them which survived and succumbed. 100% of the patients who were classified mild according to GCS survived. 95% survived according 95% of the patients who were classified as moderate survived, and 6% succumbed. 24% of the patients survived who were classified as severe, and 75% succumbed who were classified as severe according to GCS. Whereas talking of patients who are classified according to auditory evoked potential values, 91% survived. 91% of the patients were categorized as group 1 with values more than 60 survived. 72% survived when they were categorized as group 2 according to auditory evoked potential values, and less than 11% of the patients survived when they were categorized as group 3 according to AEP values. This is a head-to-head comparison of patients who survived and who expired in various groups, mild, moderate, and severe, and group 1, 2, 3 of GCS and AEP. Discrimination test through ROC, that is a receiver operating characteristic curve, and a predictive model was developed using a stepwise logistic regression. SPSS software, which is a statistical package for social science software, was used to conduct all the tests. And we plotted what is called as an ROC curve, which is a receiver operating characteristic curve. 4 simple ways to interpret this curve. It's a sensitivity versus 1 minus specificity curve, which is also ROC curve, used for both GCS and AEP. The green line in the middle of this graph is the reference line. 1. Any test whose curve comes above this reference line is significant. 2. Any curve which is more towards the left upper corner is better. So both the tests, both GCS and AEP, are statistically significant, and both of them are good enough to prognosticate head injury patient. However, the AEP curve is more towards the left upper corner, which proves it is slightly better as compared to GCS. The standard error of both of GCS is 0.061 and of AEB is 0.049, which is even better for AEB. So more accurate results can be applied when AEB is applied to a larger population. So it is more reproducible. The results are more reproducible. Whereas, and also the area under the curve for GCS it is 0.875, and for AEB it is 0.904, which again proves the superiority of auditory evoked potential over GCS. So these are the other statistical parameters. The p-value for GCS is 0.0012, and for AEP is 0.001, which is less, which again proves a superiority. Both of them are sensitive, but AEP is slightly more sensitive to prognosticate these patients, and it also has a higher positive predictive value to prognosticate head injury patients. So with all of these, we conclude, so compared to GCS, AP has higher area under receiver operating characteristic curve and higher sensitivity in predicting prognosis in head injury patients. If we discuss and if we compare them, Glasgow Coma Scale is easy to apply and is also universally accepted. However, auditory evoked potential is technically demanding. But Glasgow Coma Scale is also better for patients having ear bleed, temporal, or petrous bone fractures, or in patients having any form of hearing loss. As obviously, the sound will not be conducted to the brain, and hence auditory evoked potential cannot be used for such patients. But the pros of it is Glasgow Coma Scale is a subjective test, whereas auditory evoked potential is an objective test. Glasgow Coma Scale is difficult to interpret. However, auditory evoked potential is easier to interpret. The machine will just show you a value and you have to interpret on that. So it is much easier, much more objective. And Glasgow Coma Scale is a gross evaluation of the neurological function, whereas auditory evoked potential is a relatively specific evaluation of brainstem function. Glasgow Coma Scale, the patients who are administered sedatives, relaxants, so that will, in such patients, Glasgow Coma Scale is not effective. It will not tell you an accurate score, an accurate value. However, auditory evoked potentials are unaffected by drugs, metabolic, or even toxic encephalopathy, proving its superiority. So we conclude that both the tools considered here, the Glasgow Coma Scale and auditory evoked potential, both of them have a good discrimination ability to predict prognosis in head injury patients. However, brainstem auditory evoked potential is more of an objective test. It is unaffected by any sedation or any other drugs. It has higher sensitivity, more area under curve, and it emerges as a better prognostic factor or a predictor than a Glasgow Coma Scale, which I am sure in future will be considered for prognosticating patients of head injury. Thank you.
Thank you, Dr. Calvin, for your presentation.
Thank you.
For the last speaker, five speakers with Dr. Thomas Tommy from Indonesia. He is a neurosurgeon from Siloam Hospital, and with the title is Effect of Polinic Acid in HMGB1 expression, serum homocysteine, TNF alpha, and interleukin 10 in head traumatic model. Dr. Tommy, are you ready here or committed pre-recording?
Yes, Doctor.
Can you play pre-recording, please?
Me to speak on the second conference, ACNS virtual conference. So I would like to speak about my research about the effect of folinic acid on HMGB1 expression, serum homocysteine, tumor necrosis factor alpha, and interleukin 10 in head trauma model. And there is no conflict of interest to be disclosed. And as a background and introduction, that severe head injury is a leading cause of mortality and morbidity, and head injury significantly causes local and systemic inflammation. Corticosteroids is not recommended to be used routinely based on crash trial, and neuroprotection agents and maneuver are being developed and usually high cost regarding the usage, and also neuroprotection on the basis of excitotoxicity and reactive oxygen species. And as we know, the incidence of traumatic brain injury by WHO region, that the annual incidence highest in north of America. But if we see that the incidence of TBI from road traffic collisions usually on the third developed countries, like India and Indonesia, the annual incidence is higher. And also worldwide TBI burden, we can see Southeast Asia region is the highest number of cases in per year. The aim of and objective of this study is to find that the increase of HMGB1 expression on head injury model. Folinic acid has HMGB1 expression reduction property, different expression of HMGB1 and at 12 hours and 24 hours. Then folinic acid could influence homocysteine, TNF alpha, and interleukin 10 concentration, so that this study as a theoretical basis of therapy in management of head injury. As we know, the pathophysiology of head injury based on the mechanism of injury, mechanism of damage, and also neuroinflammation. So neuroinflammation is an insult causing tissue inflammation and release of pro-inflammatory mediators, then causing leukocyte recruitment, infiltration, and upregulation of immunity responses. And also usage of anti-inflammatory agents resolve immunity responses like interleukin 10 as cytokine synthesis inhibitory factor. And also recent trends that recent theory that there are M1 and M2 type of microglia that corresponds with the response of healing. We can see on this graph that the triggers are a lot of triggers can causing neuroinflammation, but during continuously with time, we can see that the M1 and M2 microglia is in a balance between pro-inflammatory and anti-inflammatory. So this study is based on 24 hours. So we can see at this level that all cytokines are increasing in level in its levels. HMGB1 is a gene protein, nuclear protein could bond with DNA, and it is considered as a damage-associated molecular pattern, has two domains, box A and box B. And this gene has 3 cysteine residues in the protein in C23, C45, and C106. And also work as altiol as to be has an effect of autophagy, chemotactic, and in the redox of disulfide bond on C23 and C45, causing pro-inflammatory and cytokine induction. But in all oxidized isoform, causing apoptosis. And also folinic acid is a formyl tetrahydrofolate, is a synthetic form of folic acid and used frequently as combination with 5-fluorouracil in chemotherapy with a dose of 60 milligrams per square meter square. And this drug effect in folic acid cycle, causing reduction of homocysteine, and also readily converted into 5,10-methylene tetrahydrofolate and 5-methyl tetrahydrofolate. Enters brain circulation by PCFT, folate carriers, and folate receptors. This is the cycle of methyl tetrahydrofolate, and we can see here that homocysteine is changed into methionine by methionine synthase with the help of methylcobalamin. Homocysteine is a byproduct of methionine, is an amino acid, and metabolized by transsulfuration into glutathione and remethylation into methionine. And homocysteine is a risk factor and marker of inflammation. It is an independent risk factor in head injury, causing worse outcome. In our study, we use head injury model using rat and modified from Marmaru. It's a weight drop test. And this study is experimental for randomized pre and post tests using Ratus nephrogygus sprocdoli strain, 5 to 8 weeks, 250 to 300 grams, an experiment being done in Indonesia. Craniotomy before injury was done, and we got ethical clearance from Hasanuddin University. The dropout is a death before study concluded. We treatment group into A, B, C with folinic acid head injury as the factors. And we measure the HMGB1 with RT-PCR, TNF-alpha, homocysteine, interleukin-10 with ELISA. This is the study flow. We can see 3 groups, Group A, Group B, Group C, with Group A is non-trauma with folinic acid, Group B is trauma without folinic acid, and Group C is trauma with folinic acid. And samples was taken before at 12 hours and 24 hours, and then termination of the samples. This is the treatment to the rats, and this is our modified model of Marmaru weight drop test.